So welcome to PCR TV at EuroPCR 2019. My name is Nicolas Dumonteil. I'm an interventional cardiologist in Toulouse, France. And I'm with Maurizio Taramasso, who is cardiac surgeon in Zurich, Switzerland. We're here to discuss about what we need as physicians and surgeons to know about modern tricuspid interventions. Maurizio, my first question to you would be around the topic of patient selection regarding this valve disease, that is tricuspid regurgitation.
As you know, we are still at the beginning of this, the knowledge in this field, so intervention on tricuspid valve. But we can use some of the knowledge that we accumulated in the past year from the surgical field to apply to patient selection also for intervention. Let's say that the ideal candidate, in my opinion, is a patient, of course, with severe or moderate to severe tricuspid regurgitation, which is not too advanced in the history of the disease. So right ventricle should be still okay. I think that some kind of mild right ventricular dysfunction is still okay. But of course, if we think to give this kind of treatment in a patient with really end-stage right ventricular failure, then it's going to end up with most likely in a futile procedure. So I think the evaluation of the right ventricle is really crucial, as well as the evaluation of the pulmonary hypertension. In presence of severe pulmonary hypertension, most likely this kind of procedure are going to be unsuccessful. This from a clinical standpoint. And then, of course, we have some selection criteria regarding the anatomy. We are still learning which is the better anatomy to be treated for different kind of devices. But of course, clinical and anatomy are the two parameters that we have to take into account before offering this kind of procedure to the patient.
Thank you, Maurizio. It's very clear. And maybe one thing also we can discuss is about for the patient's perspective and the referring physicians to centers who are able to do such transcatheter tricuspid interventions, what the patient and the physician has to expect as an outcome regarding quality of life improvements or other clinical outcomes after such interventions.
Yeah, of course, what we can say to our referring physician is that overall this procedure, despite they are still at the beginning of the, let's say, of the clinical application, they are pretty safe, even in, let's say, a population that conventionally is a high-risk population. So we can say that this is pretty safe. From an efficacy standpoint, I think that the target of this procedure, at least at this stage, is to improve symptoms and quality of life. And there are some initial data showing us that this is achieved if we reduce TR. So, of course, now we have some devices that are probably suboptimal in abolish TR and in reducing TR of more than 1 or 2 degrees. But there is quite a clear correlation, and this makes sense, that the more we are able to reduce TR, the more we will be able to improve clinical outcome. So I think our final target should be reduce TR, so it's an anatomical target that will translate in a clinical target. But at this stage, our target is to improve symptoms of quality of life and hopefully survival, but this information actually we don't know, we don't have it at the moment.
Okay, thanks. Second point I would like to discuss with you is imaging. Not only imaging for, as you mentioned, pre-procedural assessment for diagnosis of severity of a TR, because this is quite conventional and usual for most of the cardiologists. But imaging pointing towards the feasibility and the selection of patients for those transcatheter therapy and also for intraprocedural guidance.
So of course the gold standard method to select patient and also then to guide the procedure is echocardiography, both transthoracic and transesophageal echocardiography. We can not only measure the annulus, measure the grade of tethering and the severity of TR, we can also somehow assess right ventricular function, and this has to be coupled with some invasive and hemodynamical measurement like right heart catheterization. And then in planning the procedure also CT scan plays a major role for most of the devices in order to measure carefully the annular dimension, the distance between the annulus and the right coronary artery, which is crucial for some annuloplasty devices. Regarding intraprocedural guidance, the most used method is transesophageal echo. This is quite challenging, but evolving. So since we started with this procedure, I would say that the quality of our intraprocedural guidance improved a lot. And the problem is that the tricuspid valve is the most anterior valve in our body. So if we look at the valve from our esophagus, in some patients, the quality of our imaging could be suboptimal. Therefore, imaging is challenging. Sometimes we have to add on transesophageal echo on top some transthoracic echo guidance. Sometimes also ICE is helpful, especially to assess the annulus.
ICE is intracardiac echography.
Exactly.
Yeah.
Intracardiac echocardiography. And the new devices that will allow us to perform intracardiac echocardiography with tridimensional reconstruction will probably improve a lot and make this kind of procedure much more easy and reproducible.
Thank you. And last, I think maybe as an expert on this field and having already implanted several devices that are available, maybe you could give us an overview of what are the therapeutic options available in this area.
There are different options, and basically we can divide them according to the therapeutic target. So we have devices addressing annular dilatation mainly, so annuloplasty devices, some of them direct, some of them indirect. Then we have some leaflet or coaptation devices addressing leaflet coaptation. And then we have also some device to replace the valve, either in orthotopic position, like we do normally in surgery, or in a heterotopic position, like caval implantation in order to reduce the backflow in the venous system. So we have different devices. We know from preliminary data that we can address tricuspid regurgitation with different approach. So feasibility has been proved or is under evaluation for different devices. Of course, some of them are more advanced in their application, so we have more information. Some of them are really at the beginning. The direction that we have to work with at the moment is to assess efficacy of these devices. So to check and to prove which device works better in which anatomy. We have different approach. We know that all of them more or less are feasible, they are safe, but the missing information at the moment is which kind of benefit we can give to the patient and in which anatomy which should be the first choice device.
Okay, thank you, Maurizio. I think this was really clear, and we can summarize this as follows. There is clearly a very important clinical need for patients to have a transcatheter treatment for tricuspid severe symptomatic regurgitation. They have to expect an improvement in their quality of life rather than prolonged survival or other outcomes that we have seen in other transcatheter therapies like TAVI, for example. The screening and the guidance is crucial, and it's done by a multimodality imaging, as you summarized. And we know and we understand from your input that we are now at the period that we have already several therapeutic options that can serve and that can be used for our patients' benefits, reaching such objectives of reducing the transcatheter and the tricuspid regurgitation, and by this way improving their quality of life, improving their symptoms. Thank you, Maurizio.
Thank you, Nicolas.